Video demonstrates the physical examination of the thrower's elbow. We start first in the medial aspect, then posterior, then lateral, and then anterior in a systematic approach. We of course take a careful history. We begin with elbow range of motion. You can see the athlete here is in the supine position, very relaxed, and we can assess extension, flexion, pronation, and supination very easily in this position. And you can see a pitcher who is more mature with abnormal flexion and also abnormal extension. This player happens to be asymptomatic, so you may find that in more mature athletes. And here we go towards the medial aspect of the elbow with palpation. We're out palpating the medial epicondyle and just distal to the medial epicondyle, and that is the ulnar collateral ligament. Oftentimes we can even feel the sublime tubercle, which is the attachment site on the ulna, just deep to the muscles. And in this position, the humerus can be well controlled. The elbow can sit on the knee, and we can do a moving valgus stress test. Here we have the patient sitting, and we put stress on the elbow, and we move it through flexion extension with the valgus stress, and you can see it reproduces pain. In this position, we have even more control of the humerus. As it rests on the examiner's knee, we can move from flexion extension, we can even palpate the ligament, and for somebody who has a ligament injury, they'll experience discomfort from 90 to 120 degrees. Then we can palpate the ulnar nerve, see if it subluxes and see if it's located within the cubital tunnel. And we can also do a Tinel's. This particular patient did have symptoms reproduced by tapping on his nerve in the cubital tunnel. This is a right hand athlete. This is a right elbow, and you can see with flexion extension, the ulnar nerve subluxes over the medial epicondyle. Here's another athlete who's being considered for elbow arthroscopy who has his ulnar nerve sitting in an anterior position to the epicondyle. And this is important to examine because if we're considering arthroscopy, this is a relative contraindication to making an proximally anterior medial portal. This is an open dissection of a nerve that's subluxing, and in addition to the nerve, the triceps tendon is snapping over the medial epicondyle. There's another patient, you can see the incision, already had an ulnar nerve transposition, but did not cure his symptoms because this patient also has a triceps that snaps over the epicondyle. You can palpate the nerve, which has been transposed, but the triceps was snapping. Now we're doing a neurologic exam. In this patient, we're assessing the ulnar nerve, so we check sensation, compare it to the first, second, and third digits, especially the outside of the pinky finger and the fourth digit. And he's indicating that he has good sensory function, and we can check strength to the intrinsic muscles. Here, just by observing, this is a patient who had Tommy John surgery in the past and had persistent ulnar nerve symptoms, and you can see the atrophy. Here's another patient on his left hand. He has visible atrophy, weakness to controlling his finger intrinsics. His first dorsal interosseous is atrophied and he cannot fire it well. And then when attempted to adduct his thumb, he flexes his thumb on the left hand as opposed to his right hand. His finger and fourth and fifth digit has a flexed posture. There's atrophy of the hypothenar muscles. And you can see that on the fifth digit he even has weakness to resisted flexion. We're assessing the presence of a palmaris longus. If we're considering Tommy John surgery, we can have them flex their wrist and fingers and appreciate the palmaris. Now we're checking the flexor pronator mass, so we can palpate just anterior and distal to the epicondyle. That's where the flexor pronator is originating. Somebody has an injury in that area, which could happen in combination with an ulnar collateral ligament, which you see in the MRI scan. They'll have tenderness in that area, and pain will be reproduced with resisted wrist and finger flexion. In addition, we can assess resisted pronation, which may also elicit symptoms of discomfort at the location of the epicondyle and just distal. Moving on to the posterior elbow, first we go forward with palpation on the posterior medial olecranon. Throwers can get osteophytes in this location, and this is the forced elbow extension test. We're basically snapping the elbow into an extension position, and if there's an osteophyte on the posterior olecranon, that will be significantly painful. This is an armbar test. We're forcing the elbow into extension and holding it there, and you can see in the CT scan, patients who have an olecranon stress fracture will have pain. This is a patient who does have an osteophyte in the posterior aspect of his olecranon at the tip, and when we force his elbow into an extension with that bounce test, it does elicit pain, and it's a very sensitive exam. Often those osteophytes have a fracture to them, which is why they become painful. Moving on to the lateral elbow, we'll start with motion and palpation. The lateral epicondyle, radial head, and the soft spot. Often if there's a fusion, you can feel it in the soft spot. You can even palpate more in the inside of the epicondyle towards the capitellum. Some patients with capitellar OCD will be tender in that area. A patient suspected of having a plica, you could move their elbow in a position of pronation towards flexion, and you'll either hear or appreciate a pop as the plica jumps over the radial head, as you see in this patient. We can assess for lateral epicondylitis by assessing strength. That may elicit symptoms. First, with the elbow relatively extended, we have them resist wrist extension and also long finger extension. And if they have lateral epicondylitis, they'll experience discomfort over the epicondyle. We can palpate more distally, make sure that the PIN is not involved. And we can also assess for crepitus at the radiocapitellar joint, indicating possible OCD or radiocapitellar overload. We can palpate the triceps. Weightlifters often have a condition of traction osteophytes to the triceps, which will be tender in the triceps insertion. They may have weakness to resisted elbow extension. Moving to the anterior elbow, not as common in throwers, but happens traumatically in other athletes where they may injure their biceps. We can do the hook test where they're positioned here. They have pressure applied to their wrist and they resist that pressure, and then we can hook from lateral to medial. Here the elbow is in full extension. We have them resist extension, trying to flex their elbow, and if they have a partial biceps tear, that's typically elicits pain. And we can assess supination strength and flexion strength at the 90-degree position of the elbow. Some throwers will have symptoms related to the median nerve. They may have a pronator syndrome or a Lacertus syndrome. You can palpate the ulnar nerve very easily on the medial aspect of the biceps lying on top of the humerus. And if palpation reproduces their pain, that's highly suggestive that they have a median nerve compression neuropathy. As seen in this patient who had a median nerve compression neuropathy, we did a release and that patient did very well. Finally, we can check for thoracic outlet symptoms, and in this situation we're going to check the radial pulse, put the arm in the throwing position, also turn the head away, and we'll check to see if the pulse is diminished. We can also have the athlete flex and extend their fingers, trying to recruit blood supply, and that might also elicit symptoms. Here's an athlete who developed sudden onset of swelling in his entire upper extremity, and he has a thoracic outlet where he's had a subclavian vein thrombosis. And this, in fact, required hospitalization, anticoagulation, and subsequent surgery to take care of it. And you can appreciate his right side being more involved than his left with swelling. And then following UCL reconstruction, we do an exam in the office prior to the initiation of throwing to make sure they have adequate range of motion, no discomfort at the posterior olecranon with the bounce test, no tenderness of that olecranon. We check the ulnar nerve with the Tinel's, and we also palpate the ulnar collateral ligament, the flexor pronator mass, make sure there's no tenderness. We do a moving valgus stress test, and in this position, we have them resist forced external rotation of the arm, simulating throwing. We check their pronator strength, and we also check their rotator cuff strength. And if they have strength in all planes, no symptoms on their exam, they're ready to start their throwing program. Thank you so much.